Okay, thank you very much, Diana. Let me know if you're able to see my screen, and if you can also allow my camera so that people can be able to know who they are talking to.
Okay, just shortly. But you're able to see your screen.
Okay, thank you. Right. Okay, so okay. Yes, thank you very much, Diana, again for the very kind words and for introducing me to the team. Today, we are just going to spend the next few minutes, maybe about an hour or so, talking about mental health research and related data gaps. And then we shall also look at the role of technology. How can we use technology to address the gaps that we are talking about? Then again, confirm if I'm audible.
Yes, you're audible. Yes.
Thank you. So we shall go through some little bit of introduction to give a little bit of a background about why this topic is important. And then we shall take a dive into, the mental health research and the related gaps. And then we shall conclude with some role of technology and data science tools on how we can leverage technology, address some of these challenges that we shall be talking about or that we shall have highlighted here. So without wasting much time, the question that we have is, why now? Why should we talk about data, especially in the context of mental health or mental health research? We all know that very many people these days talk about the data, and we are saying data is the new oil. So the data revolution, not only for Africa, really is the talk of everybody because it leads to a sustainable world in which we are able to use data and generate evidence or information that can be used to plan and to deliver effective interventions, whether at the local scale or at the national scale or even at the regional level. So ideally, we all know that in order for us to be able to speak to several regional agendas such as the Sustainable Development Goals, the universal health coverage, we definitely need data because several of those indicators there, they are measurable, and we cannot do much or show progress towards the achievement of these goals or attainment of these goals unless we have data. So that is why data is a prerequisite for delivering the 2030 agenda for SDGs to ensure that no one is left behind. But what is the question? What is the problem? The problem that we have is that there is data sparsity, especially within the African context or within the African continent. And why is that a problem? Is that we have several systemic challenges which pose difficulties for us to be able to achieve informed policy making because of this lack of data. So that is really very important for us to know. Now, I wanted to use the opportunity to talk about why is mental health data important. I'm quite sure that several of you have taken some courses before this session, and some people might have alluded to some of the things. But ideally, mental health data that is specifically focused on mental health is important because it helps us to identify factors that can inform those interventions that have been proven to be effective elsewhere. How best can we scale these interventions? We also need data for that. So we need to identify what are these specific factors that can help us to scale. So for us to be able to scale the intervention that have been proven to be effective elsewhere, we need data. So, and this means that once we have data, we can be able to propose interventions that are context specific, which interventions are likely to work best at the workplace, at the household level, or at the community level, or at the individual level, or for different vulnerable groups, if I can use that word. So it could be gender or different age groups. So that is the importance of the data, that we need this data that is actually context specific. So we need to be intentional when we are collecting this data. The other reason why we need data that is really focused on different aspects of mental health is that we need to increase the volume and the quality of what types of evidence work. So what are these different interventions that are known to be either cost effective or effective, and that are feasible, and that they can be implemented at different levels of delivery, for instance, within the health sector. So what interventions are likely to work at the national level? What interventions are likely to work at different subnational levels, at community levels, or at individuals? Because what works for one specific community may not work for a different community. What works for one country may not work for another country. So that is really very important that we understand this, which we understand which types of interventions exist. The other reason as why we need mental health data is to support formulation, development and formulation of policy frameworks, and to be able to assess the impact of such policy frameworks on implementation of mental health interventions or on service delivery for people who are diagnosed with mental health challenges or problems. So we also need to understand what interventions exist for under-researched, or other people might call these hidden populations. For one reason or another, maybe because of stigma or something, we really need to understand what interventions exist that can really support or can be easily implemented within populations or for populations that are hidden, that are not easily cannot easily be reached. So that is why we need mental health data. So the question is, how do we get this data? What are the different sources of data? Or where can we obtain mental health data? Of course, we have listed a few examples here. One source could be from surveillance and surveys. So for instance, demographic health surveys, we could have behavioral surveys, surveillances. So that is one aspect. So we can use secondary data, which we can get from such different types of surveys. The other one could be observational data. So this is whereby we have intentional studies. We carry out some cross-sectional studies and we should be able to obtain the data. Or it could be through some quasi-experimental studies or some longitudinal studies, cohort studies. Alternatively, we can look at experimental studies. Of course, experimental studies have quite a number of issues to do with ethics, and that is an ongoing debate within the scientific, amongst researchers and scientists, especially when it comes to experimenting with human subjects. But that is also another source of data, and we can also get some data that is administrative. So that is one part, and this is the most common one. Then we have at the bottom here what I've called the real world data, and here I am referring to data, for instance, that we have at the hospital level in the health facilities. So this data could be health facility records or clinic records, some of which could be in hard copies, but can also be in electronic form. So for instance, in the HMIS, the Health Monitoring Information Systems. So that is really another source of data. The other newest, maybe not necessarily new, but a source of data that has gained a lot of traction these days is the use of technology and the social media. So technology, social media, and some wearable technologies like smartwatches, or and some voice patterns. So for instance, somebody makes a phone call, can be used to generate data that is of use, that can support several mental health interventions, and we can extract evidence or data from such data sets, and we can use those data sets or such evidence in form of policy, in form programming, and research. So those are different sources of mental health data. Of course, there could be other sources that I've not listed here, but those are a few examples of mental health data. So the question now is, having looked at that, what is actually available? What do we know as of now? So then I can see somebody has raised the hand. I don't know whether we can give them a chance to ask.
Okay, Nema, you can unmute yourself. Nema, are you there? Okay, I think Sainabu, I hope I pronounced it well. Sainabu, you can unmute yourself.
Thank you, Diana. What I wanted to ask is regarding when he was giving the overview on the sources of data. So because my interest is in looking at clinical records of individuals who have seek for psychosocial support, particularly psychotherapy. So I wanted to know, I've asked this question before, but I'm not very sure if I'm clear on the answer. Yes, this one on the real world data. So will these clinical or hospital records be considered as secondary data? And if they can be considered as secondary data, then how would one now identify their area of interest within that data set as a way of writing a proposal? Thank you.
Okay, so I will attempt to answer that, and you also keep an eye on the chat in case some of my colleagues answer that. But yes, the truth of the matter is that the hospital records that are looking at the clinical patterns of an individual are considered secondary data. And of course, in different countries, clinical records could be both paper-based or it could also be electronic. So if whether they are paper-based or they are electronic, it means you as an individual, you need to come up with some sort of what do you want to focus on? What is this mental health outcome that you want to focus on? That is number one. Number two, why are you interested in that particular outcome? So then maybe you have some specific hypothesis or some questions, or you have made some observations that you want to validate, that you want to study further. So that means that you will have, in the recently, it's difficult for you to go to a hospital and say, or a health facility and say, I want this data. Even if you are an employee there, So it means you will need to go through the entire research process of generating a proposal and coming up with your topic and your some specific objectives. And then you obtain some permissions. Permissions could be at the institutional level, at the local IRB level, so in the institutional review board, and maybe at the national level for you to be able to conduct that research. And that means that you need to develop some sort of a questionnaire, or what other people call the data abstraction forms, that will be used to extract only this data that is of interest to you. So if you are obtaining this data from paper-based forms, then of course you need an abstraction form, or which can be programmed into a tablet or an electronic device that then you can use. But if it is an electronic database, then you will still need a data abstraction form, because that data abstraction form gives the data manager the different indicators that would be of interest for your particular study, such that now the data manager for that particular health facility will only submit to you the data that is of interest, or that really can be used to answer your research question. I hope that answers your question.
Thank you. Just to follow up with regards to clarity. So this data set is already something that I have permission to use, but it was more like a verbal permission. So do I still now need to have like a formal permission, because it's from a private body, that like a private clinic that I already work with, and they are very happy to have me work on the data. So do I still need to now, or is it organization or institutional requirement based? Like, would it be left to them to decide, okay, we need it documented, or because we agree, you now have access?
Yes, yeah, that's a very good question, actually. I smiled there because this is an important question that has come up many times. Who owns the data? So you are taking me into the discussion of data ownership. The fact that your employer has data in their possession that has been obtained from patients as a consequence of seeking health care does not necessarily give you authority over that data as an employee or otherwise. So that is something that you need to think about. So it still means, although you have access to the data, but that data was not given to you and for purposes of some specific research. If you had a protocol, if you had a research protocol, and you obtained consent from the participants, written consent from the participants, that this data which we are getting from you will also be used for some research purposes, then there you are covered. But that consent has to be backed by some bodies. So it's not only the institution that employs you, but also we need to look at other ESCO aspects of the research process. So if you have the data still, you would not it's not only verbal permission, especially if you want to use the data for publication or for running a little bit more, because if you are using that data to inform the treatment profile of specific individuals, then that's okay. But if you are using it for research purposes, it's a different discussion. You would still need to seek approvals at the national, at the local and national levels within your specific country. But I know that each country, at least almost each country has what we call the Data Protection Act, so that you need to look at. Each country has a body which we call a regulatory body that regulates the kind of research which should be carried out and how that research should take place, and also dictates on the use and reuse of secondary data. So you may also need to check with that to be sure that you are covered. Okay? So maybe we can take one more question, Diana, and then I go back to the slides. Yes.
I cannot see any question on Q&A, so I think we can.
No, in the hand. The people who have raised the hand, it could be.
Are you too?
Response to what I've just said.
Okay. Are you too, Kabede? You can unmute yourself and ask your question. Are you there? Ayan too, sorry. Okay, well, we are waiting for him. Let me unmute Abraham. Abraham, you can unmute yourself and ask your question.
Okay. Are you hearing me?
We can hear you faintly. Can you raise your voice?
Yeah, let me ask. My question is here in the source of mental health data. My worry is we are missing the primary data like case studies because of most of the health data are hidden in the clinical setting. Because during diagnosis, they are misdiagnosing most of the time. We have to clarify here about the source of data as primary source of data, as I think adding the case study is important for me. What will be your idea here? Thank you.
Thank you very much, Abraham. Yes, of course, this is basically a sample listing of different sources of data. They are not exhaustive. Depending on the study design, you can, of course, look at other data sources. So I think if I got you very well, did you mean the case control kind of studies? Is that correct?
No, like that. Case reports, different case reports from clinical setting. It could be one of the primary,
reports, yes.
yeah, one of datas. They are not case reports.
Yes.
Yeah.
Yeah. Yes.
That case reports may have its own felt during history taking and in different history taking ways. Misdiagnosing can be happened. So to clarify that, this information should be clearly put down in order to diagnose and to get real source of mental health problems. Have you got me?
Yes, I get you very much. I get you very well, Abraham. Yeah, you are very right, definitely. That, case reports really is also very useful to understanding a specific case or a specific individual in terms of what could be the risk factors for that particular situation. So that is very correct, and I think that is also another source of data. So yeah, so this one is basically a sample of different sources of mental health data. There could be more, but thank you very much for that addition, Abraham.
Thank you.
Okay.
Thank you.
Yeah, allow me to continue and talk about the global evidence on aspects to do with mental health data. So this is basically a snapshot that in 2022, the World Health Organization estimated that about 450 million people are affected by mental health illness globally. And this contributes to 14% of the global burden of disease. It is correct? Is it not correct? Is it an underestimation? Is it an overestimation? We shall look at that. We also know that mental health problems affect about 10 to 20% of the children and adolescents worldwide. Again, whether this statistic is valid or not valid, or realistic or not, that is a question that we can look at maybe in the next few slides. And we have also seen that mental health disorders contribute to about 16% of the disease load among adolescents and young people. So these are statistics that we have. And we saw recently that following the COVID-19 outbreak, the prevalence of anxiety and depression increased by 25% globally. How did we get this statistic? So these are statistics that we know of, that have come to our attention. So, sorry about that, my screen. But let's now take a deeper dive. We have those statistics, and we are referencing them, and we are citing them, which is okay, because that is what we have. But when you take a deeper look at what is available, this graph on your screen, which is obtained from IHME, a 2019 report, we can see the number of countries with underlying data on prevalence of mental health illnesses as of 2019. So for different conditions, you can see that there are fewer of them going to attention deficit hyperactivity disorder. 172 countries, at least they were able to show data. But then what happens to some of these things we had, according to this data set, there are a number of countries that did not have data on the different types of mental health disorders. Alcohol use disorder, about 58%. Anxiety disorder, about 58%. I mean, 58 countries, not percent. 58 countries. So, yet when you look at the mental health research, you can observe that some pockets of publications that are focused on specific communities or specific regions, you will see some of these mental health disorders being reported to have a higher prevalence. So why is it that we don't have data, or countries are not indicating to us that they have this data? So this is what we have here. So this speaks to the potential for underreporting or lack of availability. Just a moment. I wanted to look at this slide. The coverage of underlying data on prevalence of major depression. This is a specific one, so we are looking at depression. And this is, that was as of 2008, which is a bit outdated anyway. And it's obtained from Baxter in 2013 there. But we can tell from here that when it comes to Africa, East Sub-Saharan Africa, so this basically shows the share of the adult population for which there has ever been research on the prevalence of major depression, which is defined as having prevalence data collected on each adult age group and gender at the share of the total adult population of that particular region. So you can see here in just toward the bottom of this graph that we have a little bit of a challenge for Africa. Central, Southern, and Eastern Sub-Saharan Africa. It is showing us that it's really very low. So why? For this particular why? So that actually speaks to why we are very keen in this particular area. I have another graph here, which actually shows that there is scarcity of research outputs in the area of mental health in Africa. So this stretches from 1903 to around 2019, which is obtained from this publication there. And we can see the blue curve down there shows the number of publications that are focused on mental health and emanating from Africa. Very, very low. Very low, almost zero, actually. If most of them is just almost zero. Maybe they are less than 10 or something like that, or less than 20 or something. Compared to the global number of publications, which have been increasing over time. So that is really important to know that despite the publication of high-profile reports and promising activities in several African countries, progress in mental health service development has been quite slow. So this is for us to really think about. I want to take a short pause here and hear what people think about this question that we have here. Why is gathering data on mental health a challenge for African countries? People can feel free to put in the chat just so that we can see, or one or two other people can raise their hand and speak to this question. Why do you think gathering information, especially on mental health, is a challenge for African countries? So Diana, you could assist me with that.
Okay, I have Nema. You can unmute and give a response.
Yeah, so thank you very much for this presentation. So I think why there is scarce of data is because of the culture or norms, because as Africans, we don't believe that people have mental health problems. So whenever you raise this issue, it's like they always say, these are not our things, these are not our diseases. People pretend to be sick, but you're not sick. You just have maybe financial problems, or you're just hungry, or you're just having other issues, but not, you cannot have, what is depression? You know, when you want to even try to explain to someone what depression is, they usually say that's not a really problem. So the huge problem with lack of data is the culture. It's not about the money, or it's not about what, but I think it's because of the culture and norms and traditions and how we are raised to, from the childhood to adulthood. We are like, these are not our diseases, these are not our thing, these are just European things are just bringing in, but these are not, they are not real problems. Like, we have other problems, but mental health is not a problem.
Okay, thank you very much, Nema, for that. Yes. So Nema talks about culture and norms, and I've seen a number of people also talk about it there, which I think speaks to what Okari Merafin is also talking about, ignorance on mental health issues. Yeah, indeed, the issue of culture, and Babayo has also mentioned it, lack of awareness about mental health. So thank you very much, Nema. Somebody else?
Amos, you can unmute yourself.
Thank you, Diana, and good afternoon, everyone. This is Amos from Kenya. I'm from Strathmore University. So I think Neema has touched most of the aspects that lead to challenges of acquiring mental health data. And I could just add that also there is, people tend to focus more on the cause of the problem rather than what they are suffering from. Like, someone is suffering from stress or depression, they tend to focus their attention more on what is causing them to be depressed or stressed rather than focusing more on and that's why most attention goes to maybe the causes and all that rather than focusing on the mental health. And then maybe I should take this chance also to ask a question. It's a general one. I was thinking, because of the dynamic aspect of mental health factors and causes, especially at this time where we have aspects like social media and all that. My question is, why can't we be allowed in this program to collect primary data? Because I know primary data could give us more up-to-date information on mental health. That's my question. Thank you so much.
Yeah, so maybe before we go to the question that you've asked, you've talked of, I wanted actually to engage you a little bit more on that, Amos. You talked of causes. Are you referring to stereotyping? But I just want to get some clarity, because I'm not a medical doctor, so but I'm trying to put myself in the shoes of a psychiatrist or a psychologist, that if somebody presented themselves to me to and with a mental health issue, then the natural thing to do would be to understand what what caused it, like how did this, okay, yeah, okay, we know that you have some challenges, you are depressed, but I would think, and in the case there are people who are more technical than me here, I would expect them to chip in and advise. I wouldn't, in my view, as a layman, I would think it's not okay to just say, okay, here is the medication, but it might be important to take the history to understand why, so that at least when we give the when the treatment is given, then that problem is not able to reoccur. So when you say that we tend to focus more on the causes than actually what somebody's suffering from, if I'm wrong, correct me. Are you trying to look at the stereotyping, like where people use, and which is associated with stigma and our culture, to say maybe this person has been bewitched or whatever? Is that what you are referring to, or not? Just clarify, Amos, before I go to your question.
Okay, thank you, Damazo. And not that actually, but what I'm trying to say is that when people present to the issue is actually people don't even notice that they are having mental health issues, because their attention more is on what is causing the issue. Like maybe someone is suffering from financial issues and all that. So they don't realize that they are depressed. That is actually so much tied to what Neema was talking about, considering culture. Our culture does not recognize mental health as such, but someone could go to the hospital not even knowing what they are suffering from, but their mind is mostly or majorly or they even try to deviate their attention towards what is actually causing the problem rather than the actual problem of mental health. So it ends up not being diagnosed as mental health, but maybe another disease that is actually causing the mental health issue. Yeah, that was my point.
Yeah, thank you very much. So I will quickly scan through some of the comments that have come here because of time. We have Anna Jaza. It talks about absence of established data collection mechanisms and priorities. Actually, this is actually in one of my slides to say sometimes the data collection platforms focus on several other things, and maybe you find there one question that is on mental health. I was earlier today in the morning actually with some of my colleagues who are looking at a questionnaire, a very large questionnaire for the demographic health survey, and trying to understand if there are questions that are focused on mental health. And we found there like 1 or 2 questions, I think, if I'm not mistaken. So I think the priorities there that you talk about, very important. Limited diagnosis, that is from Prosper Behombize. It talks about limited diagnosis and treatment centers where it would be easier to gather this data. So yes, you are very right. Because some of the health facilities, indeed, in some of the countries that are visited, you find the psychiatric clinic serving like a very large population of a very large region. So you are very right there, Prosper. We talk, there is also lack of funding from Aston, from Anson. Anson is from Zimbabwe. Serious lack of funding for research in general. So the budgets for research are far less that we have in Africa than in the developed countries. Poor health systems from Sainab, Drame. We've talked about this in terms of which speaks to what Prosper talked about earlier there, the health system is there. Yes, Aris Gita, you are very right about stigma. You are even, so this is not necessarily stigma actually from Aris. Aris talks about people living in denial. It could be, living in denial could also be a consequence of stigma, but it could also be that some of the society or the way society has nurtured us is in such a way that we don't recognize mental health as a challenge. So even when you are mentally disturbed, you live in denial, and it is related to what Kadir Muhammad is talking about there, stigma for people, because people do underreport. Katushabe Jemima talks about governments not prioritizing mental health as a problem. So that is really very important. Thank you very much, Jemima. And Muhammad Kalon Mansare talks about limited resources, lack of trained personnel to help educate the general public or population, especially for the rural communities. And then there is also, you talk about the measures for correction, to improve the system. And then you also end by talking about society norms. So I think I will pause there. And there are a number of comments that I can see here that people really understand the issues that are associated with mental health. I wanted to talk about a question, 2 points here from Godfrey Kagai and Maggie Zerari. So Godfrey talks about a point that I want to talk about, which is a lack of standardized tools for mental health disorders that can be applied across different contexts. That is a very important point. And then also Maggie talks about a lack of multi-sectoral coordination and cohesion across different sectors. So quite a number. Thank you very much. I will continue to my next slide, which talks about, sorry, I don't know why my slide is up. Yes. So this is a mental health research and the data challenges, some of which you've already alluded to, but in a quick summary, I can also add what you have already mentioned, that mental health illnesses are often underdiagnosed because symptoms are either not recognized or are wrongly attributed to, I think one of you or two talked about this, to behavioral issues or to some spiritual, so, aspects. The issue of stigma, you've talked about it. There is also actually the fear for legal culpability. Sometimes that, some self-reports may actually be withheld. Some people may fear to report somebody because maybe they might be, they may think that they might be challenged, or maybe they might be taken to courts of law or something like that. We have a number of missed opportunities, especially that some of you have talked about. Our systems and our surveys do not have enough questions or items to capture mental health, and this results into underreporting, misreporting, and lack of aggregation according to different clusters or groups or intersectionalities. So that is something that we can think about. So basically, as you have already alluded to, is that there are large gaps in the data on the burden of mental health disorders in the low and middle income countries. Because you remember at the start there in one of my slides, I showed you some statistics on the global world, and I asked the question whether this is a true picture or not. But you see, although we may know that that might be under representation, we may also not have that data to validate our claim that it is under representation. So I'm looking at about 3 areas where the gaps exist. We have gaps in terms of measurements or diagnosis. We have gaps in terms of treatment and management and care for mental health problems. And then, of course, we still have gaps in understanding what works and what works where. So that is the context. So that is really very important that we think about that. So there could be other areas, but I wanted to highlight those 3. In terms of measurement and diagnosis, that mental health diagnosis and screening is usually based on psychological symptoms. And now I remember that Amos asked the question. We shall answer your question, Amos, about why this particular project is not focused on primary data collection. So one of my colleagues will type a response in the chat why we are focusing on secondary data. Sorry I forgot to answer you. Thank you, Amos. Yeah, so as I proceed, mental health, the mental health diagnosis is usually based on psychological symptoms and behavior patterns. But we could do better if we had enough resources and funding to obtain biomarker data and conduct some brain scans and some blood tests. Because we feel, and that when we focus more on patterns and symptoms, perhaps this may not be really, it could be subjective. Whether that is objective or not, we could have some people who are well qualified and are listening in. Some psychiatrists can chip in here. On the next section, when I open up the for me to make inputs. We have, I think somebody talked about this. There is a diverse range of questionnaires and tools. One country has a different tool, one community, even within the same country, different tools, different questions. And the way we even set these questions, I know there have been some tools, for instance, that have been tested and validated elsewhere in a different contexts. But sometimes we get these tools that have been tested elsewhere and we just simply apply them in our local context without necessarily testing them and validating them to see whether they actually fit specific contexts in Africa and populations. So questionnaires and tools, if they are not validated for some specific contexts for the African continent, they may not be able to give us the information that we want. And then we also talked about communities or groups of individuals that are largely neglected, for instance, children and adolescents when it comes to discussing mental health issues. Of course, like some people have already mentioned, you will hear people say, why would a child get a mental health problem? It's just a child, or she's just a child, something of the sort. Or they say, be a man. When we take on a gender lens, be a man, you cannot just sit there. Even if you have a mental health problem, say man up. So those are some of the things that really lead to some stigma or to some, fear of people coming out when they even have mental health challenges. Look at this graph here on your screens, a very interesting graph, which really kind of shows that there are biases around gender and sex when it comes to different types of mental health conditions. So the question, when you look at this graph, you can see that some specific mental health disorders are common among males, while others are common among females. So I think this color is purple. So the purple is the mental health disorder, anxiety, mental health illness, which is a combined panic disorder, depression, mood disorders, post-traumatic stress disorders being common among females. While we have things like specific reading retardation, autism, and being common among males. So is this correct, or is it not correct, or is it maybe stereotyping? That is a question that begs to be answered through data. This is another question, another graph, Diana, where I wanted people to chip in. We could take 2 or 3 people, maybe 2 people. I want you to look at that graph and let me know what you think. Females have more mental health disorders than males. Is it true or is it false? So we can see, I see 6 people with their hands up. Diana, please, you can invite in like 1 or 2.
Okay.
Let's see. Yeah.
Okay, Nema, can see your hand is up, so you can.
So I don't think that female have more mental health disorders, but I think female are more likely to open up, and many mental health disorders are more like about emotional feelings, something like those, for the ones that involve that feelings and emotion. And females are more like to open up or to the facilities and talk to healthcare workers, something like that. But if you compare to males, males don't open up, they don't talk, they just say, no, like the culture thing still works here, like men. They're not ready to come up and say, I think I'm not okay, I think I'm depressed, I think I'm emotionally broken, or something is wrong with my body, I'm exhausted. So it's more to stereotyping and the differences of how we take things and seek help.
Okay, thank you. So that is related to what some people are talking. So women have better health-seeking behaviors compared to men. So this is what you are talking about, is some sort of a diagnosis gap. So let me explain the graph as then I will take on one or two more people to. So the graph here, if you look at it, because I've seen a comment saying I should interpret the graph. So the graph here, basically, which is from IHME, Global Burden of Disease 2019. On the x-axis here, we can see the share of females with mental health disorders, while on the y-axis we have the share of males with mental health disorders. So even for this actually picked out Africa, males versus females, you can see that we seem to be having more females reporting mental health disorders because of being below this particular line. So that is basically what those dots is what they mean. So let's take on two more people, Diana.
Okay,
Let's see. Is it a
written.
measurement gap? Is it a diagnosis gap? What is it?
The Rita, then
Hi.
Godwin.
Can you hear me? I think
Yes, we can.
it's a combination of issues, but one of them is diagnosis opportunity. I think like what one of the colleagues has indicated, a lot of diagnosis would happen when you come to a health center. So women will be diagnosed, for example, in antenatal, in postnatal, in all the various follow-ups that they get related to pregnancy. Men don't get that opportunity. And so you would think they don't have the issues, but of course the cultural issues also exist. But I've shared in the chat as well that I think on the medical side we also have a problem as medical providers, that we often do not offer the screening to people when they come to health facilities, men or women. We just don't screen. We will try and figure any physical problem and rule it out before we can diagnose a mental health challenge. And after we've done so many things, then we'll say, oh, but maybe it's actually severe stress or depression or whatever, and then start looking into it. If we were routinely, just the same way as we do blood pressure measurement each time you come into a health center, if we did that for all patients and did a mental health assessment, we would get much more diagnosis going on. But by and large, for men and women, obviously, poor health-seeking behaviors as well among men is another issue, but the stigma is also much bigger because you're seen to be weak, quote unquote weak, when you talk about mental health challenges as a man. Thanks.
Yeah, okay. Yes, it speaks to what we are saying. When a man says, I have a little bit of a challenge, people say, man up. So yes, I can see a number of people agreeing with Rita there. And I see also a few people talking about the association of mental health and associated seeking behavior with gender-based violence. Yeah, so that is also known that it is well documented that women tend to suffer more from gender-based violence, and that can actually also be associated with mental health. So one more person, I think Diana, you had given
There.
somebody an
Yeah.
opportunity to talk.
Yes,
Right.
Guardian.
Good Good afternoon. I'm Godian from Nigeria. Personally, I feel that it depends on the kind of mental health disorder that we're looking at. For severe forms of mental health, and especially when it comes to schizophrenia and co, it is commoner in males. But when you talk about mild forms of mental health disorder like depression, anxiety, it's commoner in females based on what I've seen working in the area of mental health. But also, environment also differs from one environment, especially when you go to areas where you had like forced migration, post-war environment. The impact is commoner more in women because of the association with the children and so on. So they usually get more symptoms after that condition than men. The men that actually present more are those who actually participated in the crisis, or especially like men, people who are military personnel, police personnel, or those who actually had direct hit. But when it comes to general effect, it is more on women, and that's why they manifest more after a while. Thank you.
You've really talked about I think what you raised there, which statistically, of course, there's evidence that for more severe mental health disorders, men have been shown to struggle more to be this has been shown to be more prevalent among men than women, while for mild conditions you talked of anxiety, depression, they are likely to be more in women. So could it be, this is an interesting discussion, could it be that could it refer to what some of us have been talking about earlier, that when males, because of stereotyping, because of fear, that when sometimes males get into conditions, mental health conditions, they do not seek health care. So they do not have the opportunity to address the issue earlier on. And maybe it results into an adverse condition. I would like some comment from a psychiatrist or from a very experienced researcher to chip in on that, because I'm just trying to understand how come that we have more severe conditions among males than females. So maybe because the females seek medication, seek health attention earlier on, then they are able to address the condition. So could that be the case? I just wanted to hear one more person, and then we go back to the slides.
Damazo?
All right, do I
Yes.
go on? Yeah, I think the societal norm also is a very contributing factor. For instance, if you see men fighting on the streets or in the park, people don't have, they look at it as being normal, even when the person is having anger problem. But when you see same for women fighting and tearing their clothes, then people actually believe that something is wrong, and they are more likely to receive counseling and also be asked to seek for medical interventions. So it's also the culture, and a whole lot of things actually plays a role, as well as the makeup, the physiological makeup of the male and female.
Thank you. Thank you, Godian. I will give Sainabu, I think he then was calling me, just 1 minute.
Yeah, Godian, I put this in the comments, but I just wanted to say, like, Godian, what he's saying, it's more to do with, in terms of mental health, early reporting, because if you are experiencing mild symptoms and you report early and you're giving adequate intervention, it has been seen repeatedly that people who come and report see mild symptoms will tend to recover and not develop severe conditions. But I think this can be likely linked to the gender stereotypes that we are talking about in terms of mental health issues, where in men who will not report having mild issues because, you know, you are supposed to be a man, be strong and all of those things, will now tend to develop more severe conditions because they are not receiving the intervention in the right moment. This even happens in terms of women also, because I'll give you a personal experience where when I was experiencing mild anxiety and I was not noticing it in myself because of the lack of awareness, the condition got worse over time, but that is just one case. But this has been also seen with practitioners reporting that if they give early intervention, then the severity of that symptom will not even, the risk of developing severity will not even be there. But then if you don't seek for support at the right time, then there will be more severe cases. It happens also in the condition of suicide. Like people who experience suicide ideation, if they talk about it with someone, a trusted individual, or their therapist or someone else brings up the subject with them and a family member knows and things like that, then prevention happens, as opposed to people who will develop this ideation and then they will keep it within themselves. It even gets worse and they will actually end up more likely to attempt suicide. So this, I think, I'm not sure about studies exactly looking into the correlation of why men develop more severe conditions, but I think it is safe to say it might be linked to gender stereotypes and cultural beliefs that men need to be more, in terms of like masculine toxicity, you know, toxic masculinity rather. Men will more likely, you know, have to show up and act like they are strong and they are not really bothered with certain life stressors. So that, I believe, might most likely be the case. Thank you.
Thank you. Thank you very much. And yes, I can see Grace Kinuthi agreeing with you that late diagnosis can mean the condition getting worse and can escalate into some worse conditions such as PTSD. I saw a comment here from Aran Ruchamuzi, something to do with the personality differences. I don't know that this is personality differences. Maybe that's okay. That some, you know, I think you wanted to say gender differences, maybe because women are more agreeable generally, and as such do not tend to engage more in, let's say, things like arguments with men and women, with men, fights, and which could cause more anxiety and depression. So we can see the number of interesting things here. So, but by and large, that this graph is likely to be misleading, and it could be a consequence of a measurement gap or of a diagnosis gap. There are also challenges to do with the treatment and care. Globally, the majority of those who need mental health care worldwide lack access to high quality mental health services. And I think somebody talked about it during the previous break. For instance, only 29% of the persons with psychosis and 40% of persons with depression are receiving mental health services. So the lack of care, and I think somebody talked about it, that we have fewer service centers, can also really contribute to this challenge. And we have seen that the access to treatment varies between the countries, with over 90% of those in LMICs not receiving the treatment that they need. So I wanted us to very briefly in the chat, maybe if now, because of time, it was my intention that we finish a little bit earlier so that we allow some questions. I know some of these gaps have been already mentioned, lack of treatment and lack of sensitization, limited funding. So some of these comments have already been indicated in the chat. So there are a number of really so very many different gaps, and this could vary from country to country. But you could feel free to, I want to take just 30 seconds pause for people to type in the chat what mental health treatment gaps exist in your country. What are the treatment gaps that you think or you have observed exist in your country? So if you could put this in the chat. Poverty, I'm not so sure poverty is a treatment gap. Yeah, maybe. Yeah, it's very possible that it could be a treatment gap because people don't have money, I don't know. Accessibility. So we talked about this from Bisora on Tunua. We have lack of insufficient number of mental health professionals, again from Bisora. We have drug availability from Abraham, stigma that is also mentioned there as a treatment gap. So maybe we needed to find out how we can have like a psychologists, I think so, to address aspects of stigma. Highline Morara talks about inconsistent supply of psychotropics. The capacity of healthcare workers, so that is about to treatment, so people do not afford, so that is money. So lack of professionals, inadequate medical experts, quite a number of points there that have been mentioned. And thank you very much for that. So let us see. Oh, there is Rita Sonko here who says medical schools do not do well in integrating mental health in training medical professionals. So we do not actively manage. So I think that's a good point that Rita has talked about here. I actually think that would be a very good way of trying to generate more health professionals if we can address the human resource gap that Godfrey Kagaya has talked about. And Baira More talks of inadequate infrastructure. I want to think that the availability of infrastructure is a consequence of knowledge. So if we have a country that lacks in the human resources, then perhaps we don't have enough advocates to let us know what should be or what should not be invested in. I am moving towards the end of my engagement, and having looked at all these different gaps, I wanted us to take the next 3, 4, maybe some 10 minutes as I wind up to look at the role of mental health technologies. So we know these days that definitely technology has come closer and closer, even for us in Africa, and that mental health can be an opportunity to address the challenge of mental health care and the data itself, the data collection itself. So most of us these days, we have wearable devices that we go around with on our bodies, and some of these devices can collect some variable information. One that I use actually collects information on my stress levels during the day. So that could be a potential source of information or data. We have, these days we have telephones, they collect data. We have aspects, we have situations like online support groups. You go to Twitter, now called X, Facebook or LinkedIn, there are groups of support groups where people sit or listen in and engage. We have some digital assessment and diagnostic tools, so some sort of self-screening. So where you can go in and punch in some questions and be able to get some sort of a score. There are some gadgets that deal with the therapeutic gaming. So you engage in some games, and you should be able to maybe reduce some stress levels. We have telehealth or telemedicine and associated digital treatment programs, and some different types of apps. So by and large, technology has opened a new frontier in mental health care and data collection. And that the promise of this technology to improve mental health outcomes has not been fully realized. Yet it offers us more personalized data and services. So the question is, I think that really at the top of my mind is, how best can NGOs, governments, and different institutions, research companies tap into this data? Because this data is out there, and I don't know how best we can exploit that data. Like I mentioned, I have my own gadget on my arm now. I've not seen anybody coming to ask me for my data. And I'm not even so sure whether there is any entity somewhere that is collecting the data. Maybe if they are collecting it without my consent. So the best I can do is that I have linked my gadget to my phone, and I can be able to tell a few things to myself, maybe as some sort of a self-assessment. But not everybody has that time and interest to be able to follow up on what is happening within their bodies. So even if somebody can have this gadget and they may not be able to exploit this data. So I think that is a potential opportunity that is out there. So I think, was it Amos who was talking about why not allow us to collect the data and use it as part of this project? But I'm thinking that there is already data that is existing, even for instance, through if you are interested in technology. The question is, how best can we access this data? This graph, I found it quite interesting, that a lot of money is being invested in digital mental health. So you can see the market size in terms of US dollars in billions across the years. And then there are some projections that by the year 2032, the investment will have risen to around 72 billion US dollars, which would really be a lot of investment. So the question is, since there is an unprecedented growth in the area of digital mental health, or in this particular market, how best can we as researchers take advantage of it? So that is a question that I wanted to leave to you, and that it is, there are opportunities there. And we can just discuss that briefly, but before we discuss that, is that when we talk about digital data, we are also looking at aspects to do with data science, and I'm sure there will be another session that will focus on what can the data science do. But I wanted to flash this picture here, that data science and the related advances in artificial intelligence and machine learning and data mining, we can actually be able to do a lot, even when we have unstructured data or social media data or radio data, or whatever it is you want to call it, that is slightly different from conventional data sets. Data science ideally is very important in improving the diagnosis and transforming treatments to ensure that at the end of the day, mental health illnesses can be prevented. Because we can even use aspects like GIS, to know which people are struggling or which groups of people. So we can know how people interact. We can be able to monitor lifestyles and symptoms. We can be able to tell the early warning signs for mental health. And we can be able to know what really works by using some aspects of big data. So there are a number of opportunities that we can get from the use of big data to address mental health challenges. And we can be able to use this to create benchmarks that are able to track our progress based on the different countries. So that is basically what I wanted to discuss with you today. And I will conclude by mentioning that ideally, mental health research and data, they remain scanty in Africa. And the question that is available to us is how can we ensure that the available tools for screening and diagnosing mental health are valid and reliable for the different contexts in Africa. Because like I started saying from the start, from the area, about 1 hour ago, is that what works in one community may not work in another community. The other question is how, I think somebody talked of funding. How can we improve investment in the area of generation of mental health data? The type there, mental health data generation. So we don't have really to continuously rely on external funding streams to be able to address our own challenges as Africans. So we needed to task our governments, our ministries of health, to prioritize mental health as a major issue within our different contexts. When it comes to evidence, we need to be a little bit more diverse and understand what actually works for hard to reach and vulnerable communities, as well as understand why we have prevalence of mental health challenges common among different subpopulations. We have already seen that there is evidence to say females have experienced more mental health challenges than males. And I saw a number of you urging that that is not actually what is on the ground. Maybe it's not a reality. It could be an issue of a diagnosis gap. Young adults, these days we have more young adults experiencing mental health challenges. And the lastly is to understand or think critically how we can take advantage of technology that we have. Technological and digital gadgets offer promising sources of data. How best can we integrate these within clinical health records and within population level behavioral surveys? So how best can we triangulate the data that we have, especially from these technological records, opportunities that we have? So I want to pause there and open up the discussion and hear some people's input to some of this. And as people come in, I already see some inputs from Aaron Richamos to say public data from Twitter, formerly X, formerly Twitter, can be accessed through their API. So it means that there is a need for capacity building on how to access that data. And Godfrey says, whereas if mental health has the potential to improve service provision, there is a need to review policies to facilitate increased access of such tools. Very, very important. And Daniel Rimanyasi talked of behavioral change issues can easily slide into mental health concerns. How would we draw a line through that gray area? Yeah, behavioral change issues and mental health, that is the point for conversation. So let me pause there. I want to take it back to Diana to moderate and see if there are some people who want to make input some of the comments that we raised here today, especially in the context of where are we as Africans in terms of data? What are the major data gaps? And to summarize once again that we looked at three, the measurement gaps, measurement and diagnosis gaps. We looked at the treatment and care gaps, and we looked at the what works gaps. And of course, we started off by saying that although we have some data that is available there, much of this data is not for Africa, is not actually in the African context. And even that one that is within the African context is contestable. So that is the whole summary of what has happened in the last 1.5 hours. So I will take it back to you, Diana, and I would be happy to hear people's inputs. And if some of my colleagues are here, they can feel free to chip in. Diana, back to you.
Okay, Diana asked me to just pick the question for her. So maybe we can start with Makale, kindly
But we
unmute.
didn't know who, we don't know who is talking.
This is Joel.
You have to
Sorry.
introduce yourself.
Okay.
Yes.
Okay, thank you. Okay, this is Kuria Joel. I'm assisting Diana. So, kindly Makale, could you unmute? Okay, if Makale is not there, let's have, yes, Hemsri Makale. If Makale is not there, then let's have Lita Sonko.
Hi, I just wanted to share that over the past 3 to 4 years, we have been working to look at how to increase awareness about mental health, because obviously there's a lot of misconceptions and lack of understanding what it is. And then besides that, figuring out how do we actually get people to know how they are doing, that self-assessment. So we created an app, and we have used it quite extensively in South Africa, where I'm based. But also more recently, we've had another project which enabled us to work in Cote d'Ivoire, in Uganda, and also in South Africa. And it's been very interesting working with young people and integrating, this kind of assessments as part of other programs that are trying to do youth empowerment, youth economic empowerment, and also other health programs like your HIV programs. And when you do that kind of integration and you offer screening, awareness and screening as part of a program, people come up and you discover that actually they have all of these issues that have not been diagnosed. They didn't know about them themselves. They were just struggling. And we're finding that about 25 to 30% of the young people that do the assessments actually have a potentially diagnosable mental illness. So they need then a further assessment, a professional assessment, but then you hit the problem of lack of access to those health professionals that should be doing those assessments. So there is a lot of challenges, but there is hope that the technology that we're using is helpful to increase screening and then to increase linkages and referrals to mental health services. Thank you.
So there is hope. Thank you very much, Rita, for that. Anyone else, Joy?
Yes, we also have Anna Jazz. Kindly unmute.
Thank you so much for this platform and for this opportunity. Yes, for what you have really presented today is quite relevant in our communities. And as far as what we have currently, for instance, I'm working as a secretariat for the part of developing mental health strategic plan for Tanzania. And what we see is actually we don't have any plan existing, but we are trying to develop one, meaning that we want to have at least something to start off with, because we are talking about data and we don't have any. Looking into research outputs that people have worked on, actually you can hardly find some that are really into the context of the country. And also something else that I noted is, budget allocation for mental health by the government is quite low. And I think it needs to be pushed and added more, because one of the things that is really driving us back is ownership of our own programs. And for us to be able to move forward, we really need to own what we develop. We really need to own what we make. So starting from the primary healthcare facilities to the highest levels, people need to own programs. So you can't have mental health coordinators in the country who do not know anything about the mental health plan in the country, but yet they are coordinators. So it's really difficult, but I think we will get there if people really own the programs. Yeah, thank you so much.
Thank you very much, Anna. So ownership, so we need to have this ownership of the program that are within our communities. Thank you.
Then we have please Kauselu, kindly unmute.
Hello.
Hello,
Yes, we can hear you.
I have a question. Is there any kind of work that you're currently doing on maternal health, particularly postpartum stress?
So do we have any work that we are doing on maternal health, particularly postpartum stress? I want to see if any of my colleagues can respond to that. Yeah, see if I could.
Yeah, thank you. Thank you so much. Yes, there's a group, and within the mental health data price team, a few people have already expressed interest in postpartum depression and postpartum stress may be related to that. So if you would like, we can link you up to the team, to the groups of people who have expressed interest in that area. Thank you.
So Chris, can you have your answer there? That we
Yes,
have
yes, kindly link me up with that team.
Chris, what did you want to be connected to such a group? I just know why you asked.
Yes, I'm interested, and I've been looking for such a team to work with.
Okay. Yeah, I think Joel is here. If you can put in your contact, or maybe I don't know whether you have registered, but Joel can take it up. We should be able to connect you to that group at our institution. Back to you, Joel.
Thank you. So there is one more hand from Matongoro. Kindly unmute. Jabela Matongoro.
Yes, thank you so much. Yes, my name is Dr. Jabera Matogoro. I work with the University of Dodoma in Tanzania. I'm currently reading a project on artificial intelligence for mental health, funded by the government of Tanzania through the Tanzania Commission of Science and Technology. I actually raised the hand initial when we are discussing the mental health data. And I wanted to share my experience on the question that the presenter posed out, but also on the same hand, I also wanted to share our experience on working on the mental health related research, especially in Tanzania context. So one of the challenges that we have noted, of course, most of the issue has been raised, but the lack of interdisciplinary research or collaborative research. Because, for example, by its nature, when you are mentioning about mental health data set, in a way, you are referring to ICT-based kind of field, you know. So sometimes you find hospitals or even national hospitals or referral hospitals having health information system in place, but you find the reluctance of doctors using the systems or feeding the correct information to the systems, then creates a gap on having updated and current data set for the mental health. So I just wanted to, of course, most of the issue has been raised, but the lack of multidisciplinary kind of a collaborative engagement is also contributing a part from the challenge we see. And also the second, from the experience, because we have already collected around 5,000 mental health related unique data sets in Tanzania. And in few hospitals that we we are currently finalizing the challenge or the feedback that were raised out. But what I'm just seeing is a bureaucratic process in getting the mental health related data set. For example, in Tanzania, if you want to correct data set related, of course, we have already gone through that the process and the finalized. So we are just sharing our experience. You need to go to NIMRI, you get the research clearance or research permits, and then you go to the hostel. Some hostel has also internal process. So despite of having the NIMRI clearance permit, they also need to go through the internal process to approve the proposal or the idea or the data set or the protocol that you have submitted to them. So all of that contribute to the delaying of the process. Then at the end, you will also need to go to the Personal Data Protection Commission because you are also dealing with the personal data. So you also need to go through that process. So you can imagine from our experience, just a NIMRI clearance, it is now taking us around 5 months, and you have to go online. Then the system automatically it will check. Then it will give you some. You have to correct this. Sometimes you submit. Then you get the same feedback. Then you have to wait. At the end, then the NIMRI will take the protocol to the reviewer, and the reviewer will bring the comment, and then you receive the. So you can check the process itself is very complicated. So if someone is having something that is time-bounded kind of engagement, then you can find 1 or 2 years. You are just struggling to getting the clearance and everything get started. Thanks to, for us, at least we have already gone through all those processes. But I wanted to share that experience. I'm not sure if the same throughout Africa, but I think that is also one of the challenge contributing to the lack of a mental health related data set. Of course, health related data set is very sensitive data, but I think there is a need to strengthen the process and try to reduce the bureaucratic kind of a process. And also, as the presenter mentioned, if we strengthen the collaboration, the data prize is pushing for multidisciplinary collaborations, because some of these data require ICT-related experts. If you want to see the information behind the data, you need some data analytics. You need to analyze those data. So sometimes you need some advanced kind of skills, which you may not find within the health-related sector. So that means either you need to go to the statistician or you need to go to ICT experts. So I think the multidisciplinary kind of collaboration engagement is very critical to unlock the current gap that we have identified. But otherwise, I really appreciate the topic that you are presenting. The conversation is very live, and I think it's a timely conversation, and we are happy for that. Thank you.
Thank you very much, Jabera. And you raised very important questions about, especially about multidisciplinary kind of collaboration. And I've seen a number of people from, I think, who are raising some questions, of course, starting with Priska, talking about maternal health related kind of individuals. And Grace is talking of some people who have an interest in preventive mental health care. We have Amos here, who is talking about internet and social media addiction. So a number of people have been asking how they can connect with each other. So I will ask my colleague, Mulusiu Jabena, to comment about this, because there's going to be an opportunity for matchmaking, but also to say that some of these areas that have been highlighted here, this is a recorded conversation. So we shall be able to extract some of this information and analyze it and get out some key different areas that we can use during our matchmaking. But Mulusiu, do you want to give maybe in 1 or 2 minutes talk about our upcoming matchmaking opportunity.
Okay, thanks, Damazo. Yeah, this is very timely. And I think since last 2 weeks, we have started a survey and we received about 700 individuals have responded to our questionnaires about related to their expertise, experience, and gaps they have, skill gaps they have. So we will, like, for the coming 2 or 3 days, we will analyze and match. And in the coming weeks, we will arrange a country-specific matchmaking webinar where we invite, for example, for those individuals who are interested in Tanzania and anxiety and have data science with people with lived experience expert or policymakers, we will invite them to join that webinar. And the first session will be about like linking up them, networking, and pitching their idea and knowing each other. And then we continue that discussion. And it's not one point or one-time discussion. We will continue arranging such kind of webinar, and then we will follow to have you develop your proposal, well-structured proposal and submit for this grant submission. So yes, we are coming for each country. Yeah, depends on the data, depends on the survey we receive. We may prioritize, we may start from probably, like according to the current survey, we may start from Kenya because we received large number of respondents from Kenya. So yeah, we're coming, especially by next week, we may analyze this survey and then map. And beginning from like maybe end of March, we will start the matchmaking exercise. Thanks, Damazo.
All right. Thank you very much. I think it was my intention to finish this engagement some 15 minutes ahead of the top of the hour. And I am happy to have gotten this opportunity to engage with so very many of you. I want to pause here unless there is a very, very urgent or burning question, but I wanted to pause it here. And I want to check here. I can see, I don't know, Joel, I think we asked Hemsirin and she or he didn't respond, but I see only one hand. So we can give them the opportunity and then we can pause.
Okay, we have Bayene. Country unmute.
Michael Maire Bayene.
Maire.
Okay, maybe it could be raised accidentally. Yeah, so Joel, do you have any announcement or from your end or from anybody who are the panelists that you want to make now? Diana?
Thank you so much, Damazo, for such an engaging session. We've learned quite a lot. Even me, I've taken lots of notes. It was quite insightful. So before we close, I just wanted to know how the training was. So this is a feedback session. So kindly go to menti.com. Damazo, are you able to allow me to share my screen? Let me share my screen.
You can share your screen now.
Okay, okay. Kindly confirm if you're able to see my screen, maybe through reactions.
Personally, I can see it.
Okay. So go to menti.com, menti.com. Then the code is 79269990. So kindly let us know from the training session today, what do you think went well? So know that this is anonymous. You won't know who this is, so you're not penalized or anything. So let us know what went well for today. I don't know whether people have been able to log in. So you just go to menti.com. Oh, there we go. The code is 7926 990. Okay, so I'll be taking them in as they come. The presentation was short and sweet and interactive. The training was super insightful, with the facilitators taking his time to engage us, almost felt like a physical class. Thank you, Damazo. Use the time effectively. Someone is saying the discussion was very enlightening. Another one is saying, I really like the introduction to the data landscape in Africa and what the context we were working with. Thank you for that. The training has the best and engaging. Thanks to the trainer. Yes, Damazo, it was quite interactive. The interactions were considered as requested from last week's session. Yes, we took your feedback. You wanted a more interactive session. Someone is saying the presentation was insightful. Thank you so much for that. So I'll go to the next question. Sorry, there's something wrong with my machine. Okay. So from today's session, what can be improved? What do you think we need to improve on so that we can better other trainings that are coming? Okay. Someone is saying nothing. Everything went perfectly well. Thank you for your feedback. Anyone else? Somebody is saying not too sure. It's perfect. Keep the training short. Thank you. It went well. So far, so good. Thank you. Sharing of links to cited data to help us with our own literature reviews. So probably, Damazo, you can assist us with that. Please add more references and resources according to the presentation. Okay. Continue the same engagement by other trainers. Okay, we'll keep that one in mind. Someone is saying, take us into rooms to impact more discussion, breakout rooms. Okay. Someone is saying, share additional reading resources. When you say, can recommend resources to look at to increase our understanding on the given topics. Okay, we've gotten that. Someone is saying addition of polls. Okay, I don't know. Okay, addition of polls. Okay. I don't know. Those are the few responses that have come. On the panelists, would you like to comment or add anything? But we've taken all your suggestions or your recommendation, and we've really appreciated your feedback. So I'll leave it to the panelists. Anyone would you like to say something?
Yeah, thanks. Thanks, Diana, for facilitating this webinar and for our panelists. And above all, we want to thank Dr. Kadengye for taking us through this very insightful talk and taking on board the response from participants to make it as interactive as possible. We are looking forward to engaging with you. We would like to thank you all for your questions, for your interactive engagement with us, but also with the questions that were raised. You remained resilient in that. And also for the questions that we haven't responded to, they'll come back to us on our platform, and there we will respond. For those who are interested in participating in the matchmaking, please register your names. There will be, as Modus said, the matchmaking opportunity. Yeah, so, and thank you once again. I really like the enthusiasm, and please share the links with your either partners, collaborators, people with lived experience, as we are interested in making this as inclusive as possible. So thank you so much and have a great weekend. Thank you.
Bye-bye, and have yourselves a good morning or good afternoon or good evening, wherever you are.
Yeah,
Bye-bye for now.
Thank you. Thank you and goodbye. Have a lovely weekend.